Hello, hello, and welcome to Wednesday VMR. Thank you for joining us. Stefan Zavin here, and Travis and Gabriel and Valeria are gonna um, help to run the session. And as always, we will see if anybody wants to discuss with us, and anyone has a case they would like to present. And while we're waiting, I think Steph was going to share some reflections and spaced learning from the case from yesterday. And I want to apologize to everyone who was here last week or tried to be here last week. I totally lost track of time and wasn't able to make it. I heard later that Robbie and friends rescued the hour, but I'm really sorry again for everyone who signed on and there wasn't a meeting initially.
We forgive you.
Thanks, Travis. It's been a busy week with just for some reason the hospital is like busier than usual this time of year, and then the new residents and interns, a lot of fun, but obviously need to have a different level of kind of attention and support.
So I got a chance to hear the case yesterday. Kirtan, I actually see that you're on. It was your case. Are you willing to kind of just do a couple minute summary? And then can I actually just ask you two questions that I had about the case? It was so cool. I don't know if you want to just give a brief summary of how she presented and how you got to the final diagnoses.
Yes, so glad to see you back after a couple of weeks. And yes, so it was a very interesting case. She presented during the emergency department, and it was during the COVID pandemic. So lots of patients were coming to our ED, and we never get enough time to see the patients particularly well. But she was special because she had this paralysis for quite a while, like for 4 or 5 days. She went to the local clinic and she took some treatment there. So she was prescribed steroids there because of presumably transverse myelitis, but that didn't lead to improvement. So she came to our hospital. And when we did the physical examination, there was clear evidence of paresis. So motor loss was there. So the power in all the muscle groups in the lower extremities was only 1 out of 5. She was barely able to move them. And also there was patchy loss of temperature and pain sensation. So yesterday, the Aaron, Maria, and Mohammed beautifully discussed that it pointed to spinal cord as the likely cause. But then when we did the MRI, in the MRI, the curious findings were present. So the splenium of corpus callosum was involved. Apart from that, the parafalcine, parieto-occipital white matter was also involved. And the lesion in the corpus callosum was actually quite bigger. So it was like 35 by 20 millimeter. So something by 3.5 into 2 centimeters. So it's quite a prominent one. And apart from that, there was evidence of longitudinally extensive transverse myelitis spanning all the level from thoracic to the lumbar spinal cord. And there was patchy enhancement too. And when we did the CSF, there was evidence of elevated proteins. So proteins were drastically elevated. It was around 350 mg per dl. And there was evidence of CSF pleocytosis with 70 total cells and 90% lymphocytes. So my thinking was that since she is so young, maybe there is evidence of some demyelinating disorder, but there was no evidence of oligoclonal bands. And we know that MS is one of those diseases which classically presents in temperate regions, right? So it is present in colder regions. So in India, MS is not so prominent. So I was wondering what if there is some other demyelinating disorder. And as I mentioned in the later portion while describing that there was this paper, Inflammatory Syndromes Affecting the Brain, Eye and Ear, which was published 2 years back. So in that, it was beautifully described that how various autoimmune disorders can affect your white matter. And that's how I realized that, yeah, I read this paper and maybe this could be one of those things. So in that paper, it was mentioned that Sussex syndrome, then sarcoidosis, Sjogren's, Behçet's disease, Vogt-Koyanagi-Harada disease, Hogan's disease, all of these autoimmune diseases and vasculitis can affect the white matter and can mimic the multiple sclerosis because they even have propensity to affect the optic nerve. So it can classically mimic the multiple sclerosis, and furthermore, they can exist with neuromyelitis optica. So during emergency department, when I saw those lesions, I was like, all right, patient doesn't have any other symptoms of Sjogren's or sarcoidosis, but she is so young, so she may be presenting with neurological complication as the index presentation of autoimmune disease. And we know that Sjogren and sarcoid is notorious that way. Because and so many things. So I was like, let's order it. So we ordered it and it was significant. So the ANA was like +3 on immunofluorescence study. The Rho and La antibodies were 10 times the upper limit of normal and no antibodies were present. So it was primary Sjogren syndrome. And along with that, aquaporin 4 was also positive. So it was neuromyelitis optica existing with Sjogren syndrome, and NMO usually exists with other autoimmune disorder in 40 to 50% of the cases. So it fits with the literature, and there have been documented cases of Sjogren's presenting in this way. So I'm glad that she fared well and she is now doing well. And what are the clarifications that you have?
What a beautiful summary, Kirtan, and such an instructive case. For me, I would say the case was very helpful for formalizing an illness script for NMO, recognizing one of the teaching points you had with Aaron was NMO can look like a lot of different things. It doesn't have to, so NMO, for everyone who doesn't understand, that's neuromyelitis optica. However, it doesn't have to involve the myelo or the optica at all, right? It doesn't have to have spine or visual. It can really just be an autoinflammatory neurologic syndrome of many kinds. But what I thought was helpful was a couple elements that came up in the diagnostic evaluation to help differentiate it. So correct me if I'm wrong here, Kirtan, but certainly the demographics of who it presents in are fairly similar. And so having them on the differential diagnosis for the same, this was a young woman, which would be classic, is important. But then radiographically, one of Aaron's teaching points was that the vertical nature of the lesions was much more typical of NMO versus MS, which tends not to be as vertical. And then finally, the absence of any oligoclonal bands fits just completely well with NMO, and of course is not typical for MS at all. And then your final teaching point, the fact that there was a very strong autoimmune syndrome presenting in this way really favored NMO as a primary diagnosis. For me, I think the case just really helped make sure when we say MS, we really should be considering NMO also, but knowing some of the diagnostic features are really quite different when it comes to the radiology and the cerebral spinal fluid findings. Any other comparisons you would make for us, Kirtan, so that we know how to differentiate NMO from MS?
Yes, so I guess you and Aaron covered most of the part. And the only thing is that first the demographics. So in the Asian population, NMO is very much more common, and you may not see the optic neuritis. And another thing is that in NMO, usually, as we mentioned, that LETM, so longitudinally extensive transverse myelitis will be seen, which is not typical of MS. And furthermore, MS is classically, if we see the criteria for diagnosis of MS, we need dissemination in space and
in time. I think Kirtan left us on a cliffhanger. Kirtan himself is caught in space and time right now, frozen.
Yeah, that was actually perfectly timed in space and
time.
Wow, cool.
I'll be honest, I don't think of NMO enough when considering kind of demyelinating conditions. And so it was just a really helpful case to kind of talk about what that differential is.
Thanks, Steph. Thanks, Kirtan. It looks like we haven't made much progress. Have we, Travis? Travis?
Hey. Hey.
Hey. So Travis has a backup case for us, so that's good. Kirtan, it's all good. I think we were able to finish the last word of your amazing narrative for you. So yeah, Travis has a backup case, but please guys, take a step, take a leap, discuss with us. You always learn more that way.
Alec has a case. Ooh, Alec. Alec, this is my first official VMR back, so that would be very exciting, particularly if it's an Alec-like case, which are usually really interesting and challenging and a ton to learn from.
Every time we threaten somebody with a case from me, someone always comes in to bring a better one. So I love the posture. So.
Well, I was often, since Zom and Steph have been nice enough to share their office with me, and so I made Zom forget about last week, so you guys can blame me for that one.
Okay, we have a case. Who would like to join us, please? We need the help. I have been Yay, Rafael, thank you. Awesome. Do we have a second taker? While Rafael, if you want to introduce yourself, say hello.
Hi guys, I'm Rafa. I'm from São Paulo, Brazil, and now I'm currently in my 5th year medical school. Here in Brazil, we have 6 years. It's a little different from US, because in US you have, I think, the pre-med and then the med years. And I'm currently studying for step 1, so I'll try to discuss the case today.
Thanks so much, Rafa.
So you guys just go out of high school, and from there you do a 6-year medical school?
Yes.
Oh, very cool.
Anyone else? What's the Ben Stein thing? Anyone?
Bueller.
Anyone?
Bueller.
Mario, great to see your name pop up. That would be awesome. Mario, do you want to say hi and introduce yourself for anyone who hasn't gotten to be on VMR with you before?
Yeah, of course. Can you hear me? Hi, my name is Mario. I'm a six-year medical student from Peru. I've discussed a couple of times, mostly on Wednesday, so things, I don't know why, but I always end up on Wednesdays here, so I'm just glad to be here and have the opportunity to discuss again.
Glad to have you, Mario. Mario, I've always admired the very green trees out your window. Is that just on one of the city streets, or do you live near a park? Or
I live on the 3rd floor, and the trees just end up on my floor, so I always get a lot of birds. It's pretty cool.
Beautiful. All right. We can turn it over to Alec. Alec, if you want to say hi as we're sharing the screen, and then Zavin and Mario, do you guys want to pair up and go first? And then Rafa, you and I can tackle the second part of the case together and alternate back and forth.
All right, I'm Alec. I'm a hospitalist at Baylor. Most of you guys probably know me, but I'm excited to share a case. I have a couple. I'm trying to decide which one I should share. I think we can do this one. All right, so to start, it's a 58-year-old woman with increased ostomy output. And she says she had a recent diagnosis of sigmoid adenocarcinoma. And she, about a week ago, had chemotherapy. And since then, her ostomy output has really been going up. She would typically empty her bag twice a day, but now is having to empty it every 4 hours. And it hasn't really become more like a change in color or anything. There's no blood that she noticed, just more volume. And she's had some associated nausea and vomiting, worse after eating, and also some subjective fevers. And she really denies any other symptoms though: chest pain, shortness of breath, headache, visual changes. And I'll kind of leave it there for the first outcome.
Thanks, Alec. Mario, well, what are your thoughts so far?
Well, I think I would
translate the increased ostomy output as, in my mind, as just as a diarrhea, an acute diarrhea. And I'm wondering if this patient is, I'm guessing is still on the hospitalized. So I would be thinking, okay, if I'm on acute diarrhea syndrome, what could be driving this? Is this an inflammatory or not or a non-inflammatory cause? And I would prioritize, in this case, an infectious process. If the patient is still hospitalized and has received parenteral antibiotics, I think C. difficile infection would be something on the top of my differential, and I would be thinking on those terms. The first time I've seen this chief complaint, so maybe I'm interpreting it wrong, but that would be my first approach.
All right, yeah, that was awesome. I had the exact same thought, and for a second I thought, that increased ostomy output equals diarrhea. And for a second I caught myself, I was like, is that right? Am I missing something? But unless somebody wants to enlighten us, I think that's exactly, the way to think about it. Obviously, once you have an ostomy, like there was a reason someone cut your colon or intestine and attached it to your skin, right? So the differential is probably a little bit different than someone else with acute diarrhea, right? But as far as the physiologic and sort of pathologic ways of thinking about, like, how do you end up with more than that, that's kind of how it goes. And then as far as what causes it, I think you're right to not sort of overthink it or overcomplicate it right now, because we're in VMR and Alec is presenting, so this is probably going to be not an everyday diagnosis, but cases like this, that exactly the information that we have, right, 90+% of the time, this is going to be just an effect of the chemotherapy, right? A week out of presumably cytotoxic chemo, you're having nausea, vomiting, diarrhea. That's expected, right? And if it's not the side effect of chemotherapy, if it's just acute diarrhea, unrelated to drugs, infection predominates, right? The causes of acute diarrhea and vomiting, whether viral or bacterial. So I think that's a really good start, and I think we should probably just sort of get more information before we get to fancy or uncommon.
All right. So in regards to her history, she has a history of stage 2C sigmoid adenocarcinoma, and currently she's on her 3rd cycle of chemo, and she's getting capecitabine and oxaliplatin. And otherwise, she just has a history of GERD, no other medical problems. And
what chemo was that again? You're gonna have to spell.
Capecitabine, CAPECITABINE, and then oxaliplatin. Sorry about that. And then in regards to her surgery, she had a resection of her sigmoid mass with ostomy formation about 6 months prior to her current presentation. And at that time, they thought they had resected most of the cancer. No really pertinent family history. And then social history wise, she previously had heavy alcohol and drug use, but quit about 2 years prior to presentation. No other drug use or prior IV drug use. She's currently unemployed and lives with her mom. And then just as an aside, her hospital course around the time of the surgery was pretty complicated. She got septic after the surgery and was severely malnourished, requiring TPN. And reviewing the notes, it just said that she was fungemic at that time and got a course of micafungin and improved, and went home and seemingly was doing well. Although there's some notes from her oncologist that over the months following her surgery, that her and her mom, although she was fully oriented and appropriate, she wasn't just quite as sharp as she had been before. And sometimes she would make some odd comments, but nothing else vocally. And they had ordered an MRI, but hadn't been done yet. And I think I'll stop there for the second outcome.
Just to clarify, Alec, are those kind of lapses in her cognition, are they still happening in the background now?
They are still happening. They haven't really increased in frequency or anything. They just sort of random episodes her mom or her primary doctor had commented on.
All right. So Rafa, what do you think? How can we build on what Mario and Zavin discussed with some of this new information?
I just focused on the meds, and I saw that oxaliplatin, I think is similar to cisplatin, and it doesn't have diarrhea as a side effect. It usually have ototoxicity, nephropathy, and neurotoxicity. And this other med that this capecitabine, it usually have myelosuppression as a side effect. So now I'm thinking about an infection as a major cause to this diarrhea in this patient due to the side effects of those meds.
Yeah, Rafa, I think your instincts to kind of look at the chemotherapy meds and really review all the adverse effects is incredibly important. Particularly the more unique or foreign the medication name sounds, the more we need to look into it. And I think even without either of those having specifically kind of really tough GI side effects, just non-specifically kind of not feeling well probably makes a lot of it. But I hear what you're saying, that actual kind of diarrhea and upper GI symptoms doesn't seem to fit with either. So I agree. I think infection's an important point. Are there any particular kind of infections that you're thinking about?
I don't know the major infections for diarrhea. I think is Escherichia coli, Giardia. I don't know, the Klebsiella. I think it can lead to a diarrhea.
Awesome. Yeah, all of the typical acute diarrhea pathogens we think of, very often viral, right? Things like rotavirus, norovirus, but then bacterial also, as you've mentioned. And in that bacterial category, certainly worrying about Clostridium difficile for someone who's had a lot of healthcare exposure. So I agree. I think acute onset, lots of stool output, infectious diarrhea is the way to go. I think what's interesting that Alec has given us here is this very complicated hospital course that she had prior to her surgery 6 months ago with this persistent cognitive change, right? Saying things that are a little odd. And that kind of, for me, made a quick pattern recognition to worry about Wernicke's encephalopathy as a possibility in this woman, and thus other vitamin deficiencies too as a potential reason for her diarrheal syndrome. The Wernicke's encephalopathy, it's due to the deficiency of thiamine or B1. And we've classically learned the criteria of the ataxia, the ophthalmoplegia, the mental status changes, but in fact, those are seen all together in very few individuals. And all it takes is any mental status change and chronic malnutrition to make you really worry, and in fact, just empirically treat Wernicke's. So if she's been malnourished enough for us to think about Wernicke's, it should really make us think about other nutritional deficiencies that perhaps could contribute to a diarrheal syndrome. So that would include like pellagra, another B vitamin. And again, the fact that this started suddenly makes that a little less likely, but all sort of subacute and chronic processes start at some point. So I wonder if we need to be a little bit generous with the time course of the acute onset to think of things that have in fact been building up for a long time here. I think that's really all I'll add on now. In the background, we know that she was fungemic at some point, but I can't sort of associate any that complication, which is very common with TPN factoring in right now, but we'll just have to kind of be aware that she had a fungus, probably candida, in her blood back then that hopefully was treated, but we'll see as we get to meet her and see how sick she looks to worry about systemic infection other than with the diarrheal syndrome. So we'll turn it back over to you, Al.
All right, awesome. So vitals wise, she was afebrile and blood pressure was 104/72. Heart rate was 110, respiratory rate of 20, and she was sat 97% on room air. In regards to her physical exam, generally she was awake, alert, no acute distress. She didn't have any skin lesions at that time. Her mucous membranes were quite dry, but no erythema or exudate. Her cardiopulmonary exam was within normal limits. And with her abdominal exam, she was soft, mildly tender palpation in the periumbilical region. And her ostomy, which was in the left, sort of left lower quadrant, had some watery green stool and had a little bit of tenderness to palpation. No erythema or purulent discharge. And neuro-wise, she was alert and oriented, but her attention span was kind of poor, and she seemed easily to forget some of the things that we had talked about. But there weren't any sort of focal neurologic deficits. Her cranial nerves were all intact. And I think I'll stop there. And then the next aliquot will be quite a lot of data, but I'll let you digest that first, unless you want the data first.
We can do a quick digestion so that we don't have dumping syndrome. Oh, sorry, go ahead, Mario.
Well, I think the first thing that I'm trying to see is this patient inflamed or not, and I think the fact that he's afebrile doesn't mean that that doesn't have an inflammatory process. I think that tachycardia and mainly a tachycardia make me think what is driving this tachycardia, and I'm not sure how much progress, how much more progress in terms of the diarrheal syndrome we can make with this, other than that the diarrhea has a watery character. So maybe we were thinking about maybe a malabsorptive syndrome, maybe that's less differential. But besides that, what I'm trying to think is, how can this not be an infectious diarrhea? What else could this be? Something came to mind is maybe there's some type of synchronic or metachronic adenocarcinoma occurring elsewhere in the small or large bowel that wasn't resected. And I know, for example, gastric cancers can cause a pretty significant paraneoplastic syndromes. I'm not sure. Maybe an inherited type of adenocarcinoma of the sigmoid could also have some type of remnant paraneoplastic manifestation. I'll be less likely, but that's what I'm thinking right now.
Maria, I'm like totally with you, and I think I too am just kind of like reaching a little bit to find a narrative that just kind of makes sense, because I still can't get over this timing of the chemo. And by the way, one important history maybe you could provide us, Alec, is like, I just find that the question, has this ever happened before, is just so powerful. And especially when we're talking about, we're on cycle 3 of the chemo, right? Not cycle 1. And, I do think, Rafa, maybe someone can fact check us, but I do think that diarrhea is a common side effect of capecitabine. And even though it's not like the most unique or, feared side effect of platinum chemotherapies, like they are cytotoxic chemos, and they can, all of them can cause some GI symptoms. So I really want to know, like, did this or anything similar to this happen with, the last cycles? And if it did, then it really isn't a mystery. And then the other way I can really fit in the timing is that, we're 7 days out. So we're like right nearing that point of neutropenic kind of natering where the white count, I would expect might be low at this point. And that history of prior fungemia, even if it was quote unquote adequately treated, it's very possible that, you know, some of the yeast kind of set up shop somewhere. I don't know if this patient has a port, right? And if they had this port or, you know, central line or something at the time that the fungemia had happened. But even within the native body, you know, things can hide out. You can have, you know, hepatosplenic candidiasis, you can have candidal endocarditis, you can have, you know, yeast that kind of sticks around and is kept at bay by your neutrophils. But then when you become neutropenic, you know, it comes back and you become fungemic or sort of otherwise ill again. And then in that context, you know, diarrhea, GI symptoms are a very common, just reactive, you know, response to a systemic inflammation, a stressed state, et cetera. So to me, those are still the most kind of logical and common narratives to try to think about with this story. And yeah, you're right, Mario. Also, the exam doesn't kind of move the diagnostic needle too much. It just tells us that, yeah, this patient may just be dehydrated. So let's give some fluids and see if the heart rate and blood pressure responds. And if not, this could reflect systemic inflammation, vasodilation, and infectious process.
Maybe I could add something. This patient is on, I would consider him a very immunosuppressed patient. So this could be the beginning of maybe an atypical pathogen. For example, maybe this patient could this diarrhea process be from CMV or TB or MAC or some of the pathogens we usually associate with a chronic diarrhea, but maybe this is the beginning of a chronic process. Maybe keep that in mind.
I think that's a great point. The other thing that just crossed my mind is, do you know anything about neutropenic enterocolitis? Is that, or typhlitis is the other term?
Yeah, I think, but it usually, I think it was a very severe, like a very severe syndrome. I'm not exactly sure. I think it was like translocation of a lot of the GI pathogens to the bloodstream. But I don't know much more about it, to be honest.
That's exactly right. It basically, it's just sort of like an inflammation and to some degree loss of the integrity of the bowel wall, mostly centered around the cecum. That's why it's called typhlitis, blind, but can be in other parts of the GI tract too. But Steph, am I right to think that it's usually like pain, inflammation, rather than like luminal exudation and diarrhea?
Yeah, I mean, one of the most common causes for febrile neutropenia when all other things are worked out. So at least my illness script is associated with pain in the region, right? If we're talking cecum, right lower quadrant, and then fevers most often. We'll see how this case evolves though. All right, Alec, we're ready for the data.
All right, so Travis, if you're scribing, I apologize. It's going to be a lot of information. And to answer your question, Zavin, in her prior 2 cycles, she had like 1 or 2 days of some watery stool, but nothing to this degree previously. And so I'll start with the CBC first. So her white count was 2.8. Her ANC was 2.13, so like 2130. Her hemoglobin was 11.3, and her platelets were 197. Her BMP, her sodium was 123, potassium of 4.8, chloride of 94, CO2 of 17, BUN of 23, and a creatinine of 0.9. Her baseline's around 0.5. And glucose was 117, and calcium was 8.7. As far as the phosphomatic, were both normal. The AST was 61. The upper limit of normal in our lab is 39. ALT of 16. The alk phos was 102. The T-bili was 1.3. Direct being 0.1 of that. And she had an albumin of 4. And the total protein was 7.7. And lactate was normal. The urinalysis didn't have any pyuria or hematuria. The HIV was negative. The EKG had sinus tachycardia, but without any concerning ST or T wave changes. No chest X-ray, but a CTPE with no acute pulmonary emboli. And all the hemolysis markers, including a smear, were all negative. And then CT abdomen and pelvis had wall thickening of the distal ileum, which extends into the colonic anastomosis. And there were just some post-surgical changes from the sigmoidectomy and no evidence of obstruction. And we had an enteric GI PCR, which was negative. C. diff was negative. And then 3 ova and parasites were negative. And she had a CEA level of 5, and less than 5 is considered normal. And prior to her surgery and her chemotherapy, it was like very, very, very elevated. And I think I'll stop there for now.
Thanks, Alec. Rafa, do you want to just share your thoughts first on the chemistry labs, the basic metabolic panel and the liver biochemical panel? If anything stands out to you.
Yeah, I have a little difficulty with this information, but I can try. The sodium levels, they look low. Potassium looks like almost in the maximum level. This monoxide, it looks low. So I don't know if this patient is losing with respiratory contraction or something like that. The glucose is high. Calcium, I think, is normal. I'm not sure.
Mm-hmm.
And I don't know. I think this is something about the liver, because I don't know if the alkaline phosphate is normal. 100 and.
I think it's either just within or maybe a couple points above our normal range. Is that right, Alec?
Yeah, it's within the normal range, just on the upper limit, like you said.
Okay. Protein high. The ileal thickening, it looks like an inflammatory state. I don't know.
Yeah.
That's all I got.
No, that's great, Rafa. And I think there's just so much to go through here. But what stood out to you on the labs is exactly what stood out to me. The hyponatremia, given kind of her. Salud, Ruben.
That was awesome.
The hyponatremia, given the volume loss, is not particularly surprising. We'll have to be very careful watching that as she gets better, and also make sure that hyponatremia should just be worked up appropriately too, right? We don't want to just assume it's from hypovolemic losses and not have an inappropriate ADH trigger in place from the nausea, the vomiting, the discomfort. The fact that the potassium is high to me is very interesting, right? Someone presenting with a GI losses syndrome of stool output, we typically see hypokalemia with that. And so the fact that potassium is at high normal, as you identified, Rafa, is a big surprise. When I saw that, I sort of thought, I was expecting it to be 2.8, not 4.8. So we just need to make note of that and kind of think of particular reasons why her hyponatremia could be present with a relative hyperkalemia. That pattern is something that we kind of often see in adrenal insufficiency. But I do note that Alec's team considered hemolysis, and I actually did make me wonder about, is that potassium kind of getting out of other cells somewhere with breakdown, given the fact that there's a mild AST elevation also, which can be leaked from red blood cells or from muscle cells or from other types of cells. I don't think it comes from tumor cells necessarily as they break down. So it's helpful to see that at least our red blood cells breaking down with the hemolysis evaluation is normal. The bicarbonate, that CO2 for the bicarbonate, we don't have a pH here because you're right, Rafa, to wonder what the respiratory status is doing, but it fits well likely with an acidotic process, but with a normal anion gap. Her anion gap is 12 with a normal albumin. So that goes well with a diarrhea syndrome. That's sort of the easy explanation for this normal anion gap metabolic acidosis that she likely has. And then the mild creatinine elevation, again, fits well with a hypovolemic prerenal state, given the history that we have there. I agree with you, Rafa. I think sort of where we head to now is we've got a diarrheal syndrome, and now we've got a signature in the radiology as well in the ileal region, extending to where her anastomosis is. So the question is, what could that be, knowing she's had a lot of negative tests for infection, granted, none of which necessarily have 100% sort of specificity and sensitivity, but I think we maybe need to start thinking outside of the box for what could be going on. So Rafa, any just thoughts on what else could be thickening that ileal area with inflammation other than infection, which we were most worried about?
Can it be like a sort of an obstruction, or I don't know.
Yeah. Yeah, I think the fact that she's had a colonic surgery, you know, we're at the junction really of the small bowel and the colon. It sounds like her anastomosis is further down, where some post-surgical complication is less likely, but something to really think about. And then the other sort of categories of infiltrative processes that we now maybe need to start thinking about besides infection are cancer. Mario already mentioned, oh gosh, does she have a separate new that's kind of active carcinoma that's actually causing the diarrheal output? Is one of those more indolent infections now at play that Mario and Zavin brought up before? Tuberculosis, for example, has a tropium for the ileocecal area. Is there a separate different malignancy there as well? Or is it actually just inflammation with bacterial translocation of the enterocolitis we talked about that you wouldn't really capture? You know, it doesn't manifest in the stool. Often the patient is transiently bacteremic, but the negative stool study doesn't mean neutropenic enterocolitis isn't there, except she's not neutropenic, right? She's actually got a relatively healthy white blood cell count at this point, neutrophil count of over 2,000, although she may kind of drop down over the subsequent days. The nadir after chemotherapy is usually around 7 to 10 days. So we've got diarrhea, we've got inflammation, we've got sign of chemistry lab pattern of volume loss. The question is, what's inflaming that ileal area with some of our specific markers for infection being negative? So I wonder if we're actually going to need a tissue and biopsy for that. It would really stink for this lady also to have something like Crohn's disease manifest now that she's also got a cancer in the colon, but that certainly could be a non-infectious inflammatory syndrome that kicks up in the ileum also. Why don't we keep pushing ahead with whatever other data you have, Alec, or if you want us to kind of put our final thoughts at this point, let us know what you think is best.
Yeah, so for the sake of time, I'll kind of move things along. Travis, the ANC was normal. So, I mean, like basically 90% of her white blood cell count was neutrophils. And so just for the sake of the time, this case kind of takes an interesting turn, but we ended up pursuing a colonoscopy like you guys had thought about, and showed normal ileocolonic anastomosis and terminal ileum, but a nodular appearance and loss of vascular pattern of the colon. And we had a biopsy that just showed acute and chronic inflammation with the granulation tissue. and all bacterial staining, AFB, fungal viruses, including TMV, everything was negative. Also, everything for like parasites was also negative. And we also did AFB, Congo red staining to look for amyloid. That was also negative. And so eventually we just gave her supportive care, and her diarrhea and everything, hyponatremia, AKI, everything improved. So we thought it was all just related to her chemo. But we kind of went back to these weird sort of cognitive lapses. We were thinking about discharging her, and then we got the MRI of her brain beforehand, and it was read as, Travis, I don't know if you're ready for this. So the MRI brain showed diffuse leptomeningeal metastasis of the right greater than the left frontal parietal convexity sulci, the interhemispheric fissure, and then I'm just going to type it in the chat. There's basically diffuse leptomeningeal enhancement everywhere in her brain, and that's what it was. And then I think I'll have you talk here, and then I'll have one more aliquot and then the diagnosis.
Mario, how does this, what do you think of this meningeal cancer, and how does it connect to the diarrhea or anything else at all, do you think?
Meningeal enhancement, should we say, instead of
Sure,
cancer?
sorry, yep. Good point.
Well, that's a big twist. I wasn't expecting that, to be honest. So the focus is now on what is the cause that was driving the diarrhea, causing this leptomeningeal enhancement. The fact that she's in chemotherapy for a previous cancer, which she has been operated on too. I think the link is there. Is it a metastasis from the same cancer? I think that's the first thing that would come to mind. But what else could that be? I'm maybe getting it wrong, but I believe when there was intracranial hypotension, you could also have leptomeningeal enhancement. I think you can get that enhancement too if you have intracranial hypotension. I don't think that's going on here, but maybe it's other process that's also infiltrating the leptomeninges. Could it be granulomatous process like sarcoid or an atypical infection? But I think it would be pretty tough to go against the hypothesis of this being the same cancer that was on her sigmoid now having metastasized to the brain, especially if she's had this confusion or altered mental status for a while now. So yeah, that will be my thoughts.
Brilliant. Same. It's unusual for colon cancer to go to the brain, into this leptomeninges without hepatic involvement, for example, right? That tends to be the first place where it goes, but it's possible. I've seen a couple of cases of kind of skipping atypical kind of metastatic patterns like that with colon cancer. The normal CEA is weird, but who knows? But yeah, and then the response to the primary lesion, and I don't know, something isn't like a perfect story, right? So I think we have to investigate these further, and I think the specter of atypical and missed infection still remains that could better connect the colon with these leptomeningeal lesions, because even though the MRI is calling them metastases, what it really is just signal intensity, right? So it could just be inflammation and not necessarily cancer. It could still be an infection or an autoinflammatory process even. So I think this lady would benefit from an LP maybe for kind of the next diagnostic step, and to see just what the CSF shows, along with cytology of the CSF that may actually go after, if this is a cancer, go after and find those cells and stain them and see if it fits with colon cancer, if it's a different cancer, or again, if there are no atypical cells and in fact this is some kind of chronic atypical infectious process. And then just going back to what Steph mentioned, like the sensitivities of our various tests and recognizing that at this point, whatever this is, it's a, pretty rare presentation. So just considering repeating some of the, tests we've already done for things that don't have 100% sensitivity. Yeah, that's kind of all I'll say. And yeah.
One other thing we were chatting about is in the diarrhea workup, given that the geography likely of this case is just checking for histoplasmosis also was a thought.
Great point.
I don't know how to tie that into the MRI, but just as a separate issue of the infectious category to tick off for her diarrhea. Alec, teach us what you learned with this case and how you figured things out.
So if I can, I'll just give you one sort of last information, then you can give me your answer. But so we did an LP, and like Zavin had said, the oncology team with the normal CEA and the fact that they had thought they had resected most of her cancer, they thought that leptomeningeal enhancement or metastasis would be very, very strange and not fitting. So we did the LP. So opening pressure was normal, 13 centimeters of water. She had 38 white blood cells, of which 96% of them were lymphocytes. The glucose was 30, which is lower limit of normal is 40. And the protein was 92, the upper limit of normal being 55. The cytology was negative, and all the bacterial and AFB cultures were negative. And the treponema antibody and VDRL was also negative. And the CSF stain was positive for GMS, consistent with a fungal organism. And I'll stop there, and then I can give you the diagnosis after that.
Rafa and Mario, if you guys just want to kind of share your thoughts, there's a fungus among us. So any thoughts on how we could tie together the cerebral spinal fluid findings with the diarrheal syndrome?
Rafa, you want to go first?
I just want to say about cryptococcosis. I don't know if it's related with GI symptoms, but it is usually, I saw a case last week that it was a cryptococcosis infection of the brain, and I don't know. That was my thoughts. But I saw it on chat that in the chat that Kushal said about histoplasmosis. Could be a diffraction, and sarcoid. Mario, help me.
Well, I think brain infection and fungus, the first thing that comes to mind is cryptococcal meningitis. Besides that, and besides the endemic mycosis such as histo that also can give you this presentation, maybe some atypical molds. I remember seeing, I think it was it was phaeophyomycosis, I think it was called, or maybe there's some maybe strange, maybe Kushal can help us with that, maybe some great atypical molds. But I would be, the first thing I would think is this crypto, and yes, that I don't have nothing more to add, to be honest.
I think we need to check for histo, right, where we can. So the urine and the serum, and yeah, I think about other CSF tests, including Cryptococcus. Anything?
No, I would favor histo in this case because the opening pressure was normal, because of the GI involvement, and because the cryptoantigen comes back so quickly from the serum and is so sensitive that I suspect Alec would have diagnosed this days ago if this was crypto.
Take it away, Alec. We're going to put our money on histo, disseminated histoplasmosis.
Yeah, so I was holding on to that serum cryptococcal antigen. It was 1 to 10,000, the highest I'd ever seen. And
Wow.
the CSF cryptococcal antigen was also 1 to 1,000, very high. So in the end, she had cryptococcal meningitis, and we were able to track down her other records and about this, fungemia. And so she had like what looked like a candidal UTI, but her blood cultures were pending before right at her discharge, and she actually grew cryptococcus in her blood at that time. So unfortunately had gone sort of months and had gotten chemotherapy and had not been treated for the cryptococcus. So it was a good learning case. I felt like, the diarrhea in the end was felt to just be related to the chemo. And, this was felt to be, her cognitive changes were all felt to be driven by this, and, just sort of very unexpected findings on the MRI. And, we trust our radiologists a lot, but, to also recognize that, they're interpreting things in the context of the patient, and sometimes they don't have all the information too. So, a little bit more about them than you do, to sort of use that to your advantage about, how leptomeningeal metastasis didn't make as much sense for her. And so I thought it was a good case.
Wow. And Alec, I think just that whole sort of missed part of the story of being fungemic with crypto. I even made an error when we were discussing the case because I automatically jumped and assumed Candida, right? And I think this is just a cautionary tale that very often the blood cultures will come back, sometimes first just labeled as yeast. But of course, crypto exists in a yeast form, just as Candida does. And exactly, doesn't have a tropism for the GI tract. So I think, man, the fact that you guys tracked down that infectious history, the fact that she survived through 3 rounds of chemo with this and got treatment is incredible. So thank you for the case. Gabrielle, take us home with some teaching points.
Thank you so much for the case. It was amazing, Alec. Thank you for the amazing discussion too. So at first we were discussing about increased ostomy output, and we interpreted that as a diarrhea. And in that case, we have to ask if it's a true or a pseudo diarrhea, or is it an expected or unexpected event, taking in consideration that diarrhea is a common side effect of chemotherapy. We have to ask about the tempo of this condition, the quantity, if there are previous episodes, an important question Mario and Sapen asked. And also consider some risk factors such as malignancy, as in this case, the immune status of this patient, if the patient had antibiotic exposure, because thinking in Clostridium difficile, and if the patient had a prolonged hospital stay, thinking in hospital-related infectious conditions, and if the patient also has inadequate nutritional status. Some of the categories to remember in diarrhea are watery, fatty, and inflammatory, and that categories can help us to make a diagnosis. In case of studying the etiologies, we have to prioritize infectious diseases, and other etiologies. In this case, we were thinking about maybe this could be a medication-related condition or a surgery-related. We were also talking about the cisplatin side effects. Some of the side effects to take into consideration are nephrotoxicity, peripheral neuropathy, and ototoxicity, but it's not common, the gastrointestinal manifestations. And oxaliplatin is a medication of the family of cisplatin, but we have to take in mind that this medication has less side effects, and it's not related to nephrotoxicity. Then we were looking for some clues. Mario told us a really important thing that we have to keep in mind, that the fact of no fever doesn't rule out an inflammatory process, especially in this case, taking in consideration this patient can have immunodeficient status. We were also thinking about pellagra. We have to think about 3Ds, diarrhea, dementia, and dermatitis. We were discussing a lot about infections-related conditions. One of the things that stood out is fungi related, also Clostridium difficile, and some viral Kushal mentioned in the chat about cytomegalovirus and adenovirus. In this category, the ileal involvement in infections-related conditions are TB, histo, well, not lymphoma, sorry. I will have to delete that, and paracoxy. And we were also discussing about neutropenic enterocolitis having introduced this condition, and basically it's a necrotizing inflammation involving the cecum, and usually in a context of neutropenia. The classic presentation, the triad is fever, abdominal pain, and diarrhea. Steph also mentioned about adrenal insufficiency because of the lapse of hyponatremia and hyperkalemia. Also, another manifestations of the disease are weight loss and diarrhea. And I think the pivot point was that a few leptomeningeal encasement, some differential diagnosis to keep in mind, leptomeningeal carcinomatosis, example from the lung, breast, and melanoma, hemorrhage, granulomatosis diseases, and meningitis, like TB, crypto, and viral. And the final diagnosis was cryptococcus. So thank you so much.
Fantastic case. Rafa and Mario, thank you for a great discussion. Alec, thanks for presenting, and we'll see you guys all next week. Say bye-bye, Ruben.